We've never seen anything like this. It's the #1 killer in the US for those under 50. Many were minor children. More dead each year than 3 wars that spanned 5 decades. It's everywhere. Stopping the crisis will require unity and leadership.
In this series, I'm collaborating with leading experts in what is not only a public health crisis, but many believe a national security issue, and I would argue a human rights issue. I am pleased and honored today to welcome Regina LaBelle, who is director and a professor in the Masters of Science in Addiction Policy and Practice at Georgetown University. Regina was an appointee in the Biden-Harris administration and served as acting director in the Office of National Drug Control Policy in the Executive Office of the President. There, Regina oversaw the establishment of the Biden-Harris administration drug policy priorities, which included a historic focus on harm reduction services. She previously served in the Obama administration as a chief of staff at the Office of National Drug Control Policy and oversaw the agency's efforts to respond to the opioid epidemic and other drug policy issues, including the implementation of the National Drug Control Strategy. Working at the intersection of law and policy, her work focuses on building the addiction policy workforce and using the law to promote access to quality addiction treatment, harm reduction, and recovery support services. And Regina, thank you so much. It's an honor to have you on this show. Regina, I want to start with something that might be a very basic and obvious question, but it's most certainly an important one and one that maybe there is some misunderstanding on. But in simple terms, Regina, as an expert, what are we talking about when we use the word addiction?
Sure. So the definition of addiction it's a clinical definition that's, this is a little technical, but it's in the Diagnostic and Statistical Manual of Mental Disorders. And why that matters is that clinicians can then diagnose and then treat someone with a substance use disorder. So a substance use disorder, it also includes gambling disorder. It is the use of a substance or gambling despite negative consequences. And it can be chronic and relapsing. And as with any other chronic condition, the earlier you intervene, the better it is that the person can be treated appropriately and go into remission.
So when you say a use disorder, or more commonly today, we hear the phrase with respect to drugs, substance use disorder. Are those synonymous, addiction and substance use disorder?
Yeah, I mean, addiction is the broader category that does apply to gambling disorder. Gambling is in the DSM-5. And a substance use disorder can include alcohol, tobacco, and other illegal drugs.
There's been a lot of controversy about addiction for many decades and longer than that. And more recently in the past, and you'll know this better than I will, but most certainly in the past few decades, we've shifted, experts and most certainly public opinion has shifted from this idea of kind of this libertarian free will where you can just choose to stop. It's just a simple choice, to this idea of a disorder which resembles something more like, say, diabetes, something that is a physiological condition. Can you speak more to that, this idea of substance use as a disorder versus something someone merely chooses to do?
Sure. So the initial use of the substance is obviously something that, is a choice that someone makes. Not everyone, though, who uses a substance develops a use disorder. So the DSM, the diagnostic, the statistic, the manual that clinicians use, it categorizes addiction from, there's a number of symptoms. So if you have 1 or 2, it's a mild case. easier to intervene. If you have all 11, that's when it is much more serious and severe. So, but I do think that we have gotten to the point where we're accepting that if someone does have a substance use disorder, it's no longer, we don't consider it a moral failing, that individual is just a bad person, and that's why they developed a substance use disorder. And we recognize that, any one of us can develop a substance use disorder.
And so in your work over the past, several decades at a very high level, you've seen this graduation from stigmatizing people to general acceptance of this as a disorder versus a mere choice.
Yeah, I think we certainly are getting better. But think of, anyone who's been around someone with a substance use disorder. I think sometimes we still carry that with us because, it could have been a really difficult situation because, addiction is the use of a substance despite the consequences. And those consequences can reverberate in a community, they can reverberate in a family. I do think we've gotten better in terms of the stigma. We're not where we should be I just read something yesterday where as a punishment, you could take away someone's medication that they use to treat their opioid use disorder. There's no other drug this was in a carceral setting. There's no other drug where you would say, well, you're not behaving correctly, so we're going to punish you by taking away that drug that treats your condition. So I do think we're getting to a better place, but we're not where we should be yet.
It's so interesting because my training is not the same as yours, but my training in my undergraduate and graduate work was in philosophy. And there's a lot that's been written about this idea of free will versus determinism. And one of the things that's always perplexed me amongst the population of people that really have this very libertarian view of choice, meaning, if you're poor, just pull yourself out of the bootstraps and get a job. This very simplistic view is that those ideas of, simple choice, just choose to not use fentanyl anymore or choose to whatever it might be, works really well when it's applied to other people's vices. But none of us, if you're watching right now and you hold that view, I don't think we have many people like that. Go ahead and just simply choose and then fill in your blank, even if it's something like procrastination or worry. It's just not so simple to make a choice to stop whatever that thing that you oftentimes say, darn, I did it again. I wish I could just stop. Life is far more complex in many cases than simply choosing to quit. You've been a pioneer in many ways with respect to what's called harm reduction. Now, I'm, again, newer to this space and knew the phrase and knew the term for the last few years, but as I'm out speaking to dozens of people in my work, it's still a phrase that many people are either completely unaware of, or in some cases, I think mildly to maybe severely misguided on. And so I want to talk about harm reduction with you for a moment and ask you simply to tell me what it is.
Sure. So harm reduction is both a set of tools and an approach, a philosophical approach to people who use drugs. The set of tools that are available for harm reduction include syringe services programs where you can get a sterile syringe and that reduces the rate of HIV and Hep C. So the reason why, especially now that we have, we've come down a little bit in overdose deaths, but with this historic rates of overdose death, that's why harm reduction has become even more important. Because you can't expect everyone who is at risk for an overdose to just wake up one day and say, oh, I'm going to get treatment, even if it's available, even if they can find the right type of treatment. So we need to make sure they're getting the tools that they need, so they're reducing the harms that are associated with substance use. And harm reduction has been part of the public health community for a long time. And so think about, when you have put a seatbelt on, when you wear a helmet on your bike, those are harm reduction tools. And we would love everyone to drive safely. We would love for accidents never to happen. We would love for people not to speed, but they do. And so we need to reduce the harms that are associated with that. Now, I'm not equating, the use of injection drugs with speeding, but it is a harm reduction is a public health tool that it shouldn't be politicized, but it's become political. And because it seems counterintuitive to people that you're giving someone the tools by which they could be harming themselves.
Right.
And think about, they're not. It's giving them something that will protect them from harms. And then the philosophical approach goes back to that stigma. The philosophical approach of harm reduction is accepting people who use drugs as human beings who are deserving of our help. And harm reduction is about meeting people where they are, but not leaving them there. Mm-hmm. So it's important that we not, be too political about it, but it obviously has become very politicized.
I have so many thoughts. One is, it just seems like there's a logical sequence, because if one can't get past this idea that substance use disorder is a condition, that's going to affect their view of harm reduction. Mm-hmm. It seems. What's the major pushback? Because from what I know about harm reduction, what I haven't seen, maybe I've seen it in some certain towns and states on this part of the country, if you will, but there doesn't seem to be this kind of wanton view of let's just give these people all that they need so that they could be as high as they want and die. But that's kind of some of the tropes or canards that you hear out there. Mm-hmm. That it's just this very radical view of just letting people use with no intervention or no tools inside. Can you speak more about that?
Yeah, use without consequences, because the consequence itself, the thinking is the consequence itself is going to get that person to not use anymore. But the consequence itself, if you think about what we talked about initially, it's the definition of addiction is the use of a substance regardless of the consequences. So I'll give you a good example, naloxone. So naloxone is the drug that reverses an overdose. It's a miracle drug. Mm-hmm. And
with fentanyl, right?
With fentanyl, yes, heroin, opioids generally. So when I first started working in this, there were many people who really opposed having broad access to naloxone.
What?
For a number of reasons.
Okay, I'm so ready for them.
Well, one reason was that people needed to have that consequence. Oh, wow. And that would shake them up so that they would go get treatment. They had to hit rock bottom. But rock bottom, when you're using fentanyl, typically is death. And so that's why when we see the numbers come down in naloxone for overdoses, there hasn't been enough research to see exactly what the reasons are, but we have a lot more availability of naloxone today than we did 10 years ago. And one of the reasons is because we made a real effort when I was in the Obama administration. We made a real effort to get naloxone in the hands of people who would use it, but also we started with law enforcement because we knew in many areas law enforcement could be an important conduit for assistance if they were the first ones to show up in a rural area, but also it would help reduce the stigma of naloxone if you had law enforcement carrying it.
Sure.
And so now, obviously, we need, much broader access to naloxone than we currently have. Much more, easier ways to get it. You can now get it over the counter, but it's still $45 over the counter, and it's locked up in some cases. But naloxone is a really good example of a tool that we had to get over that stigma about harm reduction in order to expand it.
It's fascinating. I came into this space, and I've told you this before. I mean, I stumbled into this when I was on a writing retreat in northern New Mexico, and there's a town that I would drive through that I didn't know at the time, but has a long history of uh, opioid addiction, going back to 2008 when the New York Times did a feature article on this, and last year the LA Times did. And I started wanting to learn more, and I started volunteering at a shelter. And it was really fascinating for me, Regina, having not worked in the field, if you will, to just speak to those using. Now, these are men and women who would go to the shelter for food and to spend the night. Many times they would choose to sleep in single digit weather as opposed to sleeping the night there and having to not use. That's a whole other topic. But the way they would describe fentanyl, and these were former heroin addicts, so they like the opioid high, which is a total relief of physical and emotional pain, which is why people like the stuff. But they would be told about the high risk involved in continuing. They smoke it. A lot of people smoke it, as you know. And I was speaking to someone yesterday who worked at the shelter, and I hadn't spoken with her in 6 months or so. And she was telling me about a lot of her friends that use fentanyl. And she said it's just so cunning. And now this is kind of addiction talk right now, but she said it's so cunning because she said every one of them will say, they won't say fentanyl. They'll say, yeah, I'm using blues, but I totally regulate. And it's, with 70,000 people dying a year, the majority of those, of course, are people that we know are using. Again, just to underscore your point, which is that's the definition. And despite the high risk of fatalities, and they've all had people that have known people that have died, there still is this continuation. It's insane.
Yeah.
Okay, so harm reduction is taking this idea that there's a disorder called substance use disorder. It's not as simple as just simply kicking a habit or just saying no once and forever. And so given that person P is going to be using it, we don't want that person to die in the same way that we don't want people driving to die if they're going to be driving anyway. Other countries I've read are, and I don't know if this is saying it the right way, but they're maybe further along than we are with respect to harm reduction and most certainly treatment of substance use disorder. And I've been hearing about Portugal. So what I want to do now, because you have worked in the White House on this issue at a very high level, why is the U.S. where it is, let's say, compared to a country like Portugal that some would say are just having more success with respect to addiction and drug fatalities?
Yeah, Portugal's a good example. We had the Portuguese drug czar come to Georgetown to talk about their approach to addiction and harm reduction services last year. And it was great to hear it directly from him because he's a medical doctor. Because the Portuguese drug model is kind of a Rorschach test that people use to promote or support whatever model they or whatever ideology they have. The interesting thing about the Portuguese model is that it's a small country, obviously, and they have universal health care. So if someone is stopped for public drug use or some other crime related to their substance use, they go to these regional panels where they're interviewed. And the regional panels, comprised of social workers and other folks, determine what that person might need. They don't incarcerate them. They say, what's going on and how can we help? And so it's very individualized. Now, the United States does not have the individualized approach for a number of reasons. One is the social safety net in many areas is just not there. It's just not present. And for many years, we have taken the, out of sight, out of mind. If we have a tough approach, we're doing something. This is not, we didn't get into this issue overnight. It's going to take a while. And I do believe there needs to be an all of the above approach. Portugal, interestingly, did not legalize all drug trafficking. And so drug trafficking is still enforced in that state. But what they're in that country, well, what they're doing really is, again, is that individualized approach and connecting people to services. And they were very successful at reducing heroin overdose deaths. At the time, it was late 80s, early 90s. So, I think that there are lessons that we can learn from other countries, and we are moving towards a better approach to substance use disorder generally, but it's taking a lot of time.
Without that safety net, or maybe said another way, lack of access to treatment. I was speaking with a mother who sadly lost her son at my alma mater's dorm this year, UCLA. Of course, you've met these parents. It's the saddest thing you've ever seen before. And she was saying that he had a use disorder issue. She was saying that when he did go into, and I don't remember the specifics, it might have been the ER or might have been a hospital or a doctor. She said, he was 21 years old, and there was this kind of attitude of come back in 4 or 5 months. It's not urgent. She said it was so hard. I'm not getting the specifics exactly right, but I think what you're referring to is a contrast between a country like Portugal with just general access to medical services. I lived in the UK for years, and I was warned about how horrible universal health care is, and I'm not making a pitch for it. I'm just simply saying it wasn't as bad as I was told because you always had access to it. Mm-hmm. So it sounds like a country like Portugal is just further along in being able to offer services to people struggling with substance use disorder. How are we doing in moving toward more accessibility for people with this disorder?
Yeah, so a couple goals that we had when I entered the administration in 2021 was to expand access to these medications. And there were rules that were in place around methadone and buprenorphine that really didn't only not follow science, but they really didn't make sense. And so for the first time in decades, the rules regarding methadone, which is one of the 3 medications to treat opioid use disorder, it was relaxed. During COVID, you could go to a methadone clinic and you could take home the methadone. We didn't have an increase in methadone-related overdose deaths during the time. We didn't have an increase in diversion, which is using it for something other than what it's intended. So it's a natural experiment. And so we were able to, the administration issued these new rules around methadone that allow people to have a life and go to the methadone clinic. Because if you have to go every single day, what if you have a job and it's a 40-minute ride to the methadone clinic? What if you have a child that you have to take care of? So I guess the point is that we've put all these barriers up that aren't science-based or not evidence-based, and they're like we think we can punish this condition out of people, and that's simply not the case. We have to make it, this has been said over and over, we have to make it as easy to get evidence-based treatment and other services as it is to get the illegal drugs on the street.
What would the opponents of something like methadone, which is a harm reduction, falls under the umbrella, it's a loaded question, but what would their objection be?
So originally, the objection to allowing more take home, there were 2 objections. One is that, methadone is a very strong medication. And so you need to make sure that someone is observing you when you take it to make sure everything's okay. So that was one objection. And the other one was that it would be used for purposes other than the treatment of opioid use disorder. Now, both of those things we found out during the natural experiment during COVID that didn't happen. The sky did not fall down when we allowed people to have more access to methadone for opioid use disorder. So these are not, someone has said this to me repeatedly, so I need to copy it. We do these policies and we don't think about, and then what? So we have good things that we put in place, like getting rid of the buprenorphine caps. And again, one of the other medications to treat opioid use disorder. And then what? What do we do after that to get more doctors to treat people with opioid use disorder? Because we don't have more doctors treating people with buprenorphine. And then there's a lot more we can do to expand access. And it's not just about access to treatment. It's also, for many people, it's housing, it's employment. There's a bunch of other things that come after. And that's what the and then what is.
Absolutely.
Getting people employment, helping people sustain their recovery, because treatment is not an end in and of itself.
We have an Instagram account, and one of the pinned sayings is, we need to stop the stigma. I get it. I understand it. I've spoken to people about it. And on this call, I'm still amazed at how radically powerful the stigma is. And what popped into my mind was speaking, I speak to different parents who lost children, and many of them, especially the fathers, will not tell anyone about it.
Yeah.
And I was speaking to one yesterday who said that, and again, this might be taken the wrong way, but he said, I think a lot of men feel like their responsibility as fathers is to protect their children. And he said, I just feel like my son had a back injury. He got prescribed morphine or something. He got hooked. You've heard the story 100 times. He got hooked on opioids. It led to other things, and he ended up overdosing the day before he was supposed to go to college. And this is a upper middle class suburban area and socioeconomic status. But he said it's just still the stigma around. His son had diabetes, but it wasn't diabetes. It was a substance use disorder. And yet I wonder, and this isn't exactly anything I planned, but it's interesting how with alcohol, and I know people have written books and given seminars, and this has been talked about ad nauseum, but the stigma with alcohol is nothing close to what the stigma with any kind of, we're talking still about substances that cause addiction, but it's really remarkable how there are plenty of people with alcoholics, I guess, or however you say it these days, but that stigma does not exist in the same way.
No, not only doesn't it exist, but we have a year where we take our kid when they turn 21 for their first drink. Not only does it not exist, the stigma, but we celebrate it. And I'm not a prohibitionist about it, but I think it's something that we need to recognize.
Absolutely. And why would there be a difference? And again, I know you're an expert in this, but why would there be a difference? Because if ultimately we're talking about substances, substance A, B, C, maybe meth is one, and opioids are one, and alcohol is one. If you abstract from the kind, the species is addiction or substance use disorder, and yet that stigma still is so strong. So it sounds like what you're saying then is that we have a long way to go, but thanks to a lot of work from different people in many different fronts, we are as a nation moving in the right direction.
I think we are. And I really applaud those parents who come out, and it's hard, because you feel like you're a bad parent if you lost your kid. Like there's something you did wrong. And I applaud them for talking about it, for, being there, and for others so that they don't go through it.
What has this journey been like for you? It's 2024. Everybody's heard the word fentanyl. I say it. If I've learned anything in 7 months of launching this organization, it's that not 9 out of 10, but 19 out of 20 people I speak to do not know what fentanyl is. They've heard the word, and then they just think, oh yeah, cocaine and heroin, and you got to just say no. That's literally what I hear, including from a tenured university professor at the University of California 2 weeks ago. So what's it been like just in this, if you will, journey of fentanyl starting around 2015 until today?
Yeah, I mean, I remember specifically, so we had a little dip in overdose death rates. I think it was 2012, and the USA Today had a front page when they used to have front pages. They had a story about it. And I remember saying, we can't spike the ball because we don't know what's around the corner. And I'll tell you though, that fentanyl wasn't on anybody's radar. We didn't even have a code. So we saw deaths going up, and our data folks were like, well, we think it's this other substance, but we don't have a way to track the deaths because we didn't have the mortality codes for that substance. So then we got the codes and we saw it going up.
I'm going to wonk out a bit, but what does that mean? Like a code?
So it's an ICD-10 code, basically, that identifies what the primary substance is that was involved in the death.
So in computer systems, you got to put in a code.
Yeah, so CDC has the National Center on Vital Statistics, and they do all this. They get the mortality data from the states, and then the feds kind of clean it up, and that's what we get. Now it's reported monthly, but at the time we only got it annually. So it was hard to know what was coming around the corner when you saw the last 12 months. It was not great.
Wow.
So it did show that we had such a criminal justice approach to it that we didn't even have the data that we needed to figure out where the heck we needed to go from a public health perspective. So I do think, I'm not cynical about this. I know that we're in a horrible situation with all these overdose deaths, and it's never fast enough. We are in so much of a better place than we were back then. Everything was criminal justice focused. And as I said, I believe that there's a role for that, but not for the entirety. This is a public health issue. And we need to have the funding. The funding for prevention and treatment has caught up to the funding that we spent on transnational criminal organizations. And we have a lot more engagement with the Centers for Disease Control and Prevention and other HHS agencies. So over time, we had the first drug czar, Michael Botticelli, the first drug czar with a public health background who was in recovery. And we celebrate Recovery Month every month. We are in a much better place than we were back then, 10 years ago.
Can we talk about the difference between if you're at a party and you're going to drink, you have to have a physical glass and people can see it and it's full of beer or whatever you're drinking. Or if you're, smoking marijuana, it seems like this pill culture that we're in is cunning, because someone could be using drugs and have a few pills in his or her pocket, and you would really never know. It's a different kind of, is this making sense? It's a different kind of relationship with the substance in the pill culture that we're in today, which obviously the Mexican cartels are very fond of that reality. Can you speak to that at all?
I think, I think it goes back to that whole awareness about the dangers. And then one of the other harm reduction tools that can be used is fentanyl test strips. Mm-hmm. So you'll know what you're getting.
Yeah.
And so you're not, you'll be aware that if you have this pill, that if you test it, you'll know whether or not it contains fentanyl. I hadn't really thought about how people use it, pills versus it's accessible, and you think that it's safe because it's a pill and it might even have a little emblem on it, might even have a symbol on it that looks like a prescription. And there had been research early on in the overdose epidemic where parents even said, I'd rather have my child take a pill than, a prescribed pill than an illegal substance, because at least they know what they're getting. That has changed over time as people have more awareness of pills. But I think that, certainly it's an easier way to use it. So the barrier to entry would be lower.
Right. I hadn't thought about this really. I don't know if I had much until today, but, I'm thinking of Breaking Bad right now. But for a long time, if you were going to use an illegal narcotic, you were going to have a bong, or you were going to have these meth pipes, or you were going to have a needle or you're going to have to put some rubber around your arm and find a vein. So there are these, kind of steps or props that were necessary in order to get your high. And it just seems like a pill seems kind of innocent. I mean, most kids had taken an Advil when they were sick when they were 12, or, and I just wonder sometimes if psychologically a pill seems more benign. We most certainly know that it's not in the case of fentanyl.
Yeah, and when the new initiates, so people who are just starting to use, they're not going to start by using something with, one of the drug paraphernalia pieces you just mentioned.
Paraphernalia, yeah.
They'll start by drinking or with a pill, because it's a lower barrier to entry, and certainly the traffickers are aware of that.
Well, Regina, one of our charter is United Against Fentanyl, is a new organization in this space, is to work on what is in the beginning stages of a comprehensive approach. And so for us, we applaud and laud. One of our board members works for a naloxone organization, and that's what they do. And they're getting naloxone into places where it needs to be. Mm-hmm. We're looking at this as we have foreign policy issues. If the chemicals stopped coming from China, that would help. Even if it was cut in half, it would help. If the cartels, if something was able to happen where they were making and shipping in less, that would help. Border security, especially with legal ports of entry, would help. The dealing issue and finding ways. And then you have the other side of the coin, because that's all supply related. Which is what you've done for a very long time, which is trying to find ways to either reduce demand or deal with treatment. And I just want to say that, again, when I get into conversations and I'm offered a choice as, which one are you into? It's a supply problem. No, it's a demand problem. The more I learn about people like you and the work that you've done, and there are many like you, as your colleagues, we need to be very grateful for you and the public service that you have invested in not just our nation, but in thousands or millions of lives. So it's an honor to have you, Regina. I thank you so much for being part of this program.
Thank you very much. Have a great day.
You too.